I'll just introduce myself. So my name is Daniel Stemen. I'm the manager here for the Respiratory and Interventional Pulmonary Services departments for Keck Medical Center. Um, this lecture is designed for nurses. Usually, I give it to the Versant nursing program regularly. So what I'm going to try to do is just do some general ventilator overview and just sort of reuse this. Okay. I didn't have time to throw a custom together for our session, so please bear with me. Are you ready to get started, Tiffany?
Ready to go.
Awesome.
Jane, is this set to go?
Yes, can you not see it?
Yes, we can see it. Just want to
Okay.
make sure it's in a view.
Well, go ahead and go to the next slide then. As many of you may know, there are many types of ventilators with a lot of software these days that govern the different strategies for ventilating a patient. And the keys that I kind of want to go over is what we're looking for in this emergency surge environment is some minimums for useful devices in this space. Since the COVID disease causes issues that would not be overcome with just a ventilation component, we need to focus on devices that can provide high levels of mean airway pressure and therapeutic pressures to provide oxygenation support to patients. Are you able to get into the slides a bit? We're kind of just sitting on the first one. So to summarize, we have this COVID problem. It causes a pneumonia. It causes a increase for needs for oxygen. And one of the key components in mechanical ventilation in terms of therapies is to use higher pressures in the lung to increase surface area of the lung, as well as reduce the oxygen membrane barrier, providing pathways for increased oxygenation and decreased shunting. Go ahead and move to the next screen. So just a brief history. Back in the day, polio, we had these negative pressure ventilators. They're super dangerous. It's very hard to regulate those safely, especially with where technology was then. And all modern ventilators today are positive pressure ventilators. Go ahead and move on. So these are the different categories of modes of ventilation. We can use really either or the control mode or the assist control modes for these COVID patients effectively. Since much of our strategies are going to involve paralysis and sedation, these two modes are going to be the core. Go ahead and move forward. These modes are going to allow us to ventilate the patients in ways that are effective and get the best use out of the devices in the most efficient way. One of the problems with treating these patients is that they use ventilators for extended periods of time. And so one of the things we want to be able to do is treat them as quickly and efficiently as we can so that ventilator utilization is optimized. Continue on. Assist control is the most common category of ventilator software. This category allows for a designed machine breath for the user to create manual breaths or machine breaths that are dictated by the provider and team. This mode also allows for patients to breathe spontaneously in the way of triggering breaths. Although in this mode, when they trigger breaths, they are triggering a machine breath instead of a more spontaneous or supported breath. Sorry if this is unfamiliar territory, but I'm just going to run through it as quickly as we can, okay? The mode that we're going to see used most often, I believe, will be, especially in these primitive and newly and rapidly developed ventilators, is going to be pressure control. So it's going to be assist control, pressure control. Let's move on. And we're going to skip that one. One of the other key components of mechanical ventilation for these patients with oxygenation needs, these hypoxic patients, is a very tight control over the PEEP. PEEP is positive end expiratory pressure. This is a baseline pressure that we use to help keep the lung inflated at all times. It helps us reduce driving pressure. It also helps us increase mean airway pressure to treat patients with high means to again support oxygenation. Let's keep moving forward. We're gonna just go over this quickly, but the pressure control mode, this is actually a good slide for those designing software for pressure control. This mode is going to be pressure set or pressure limited. Flow and volume, of course, will be variable when you focus on pressure. And we're going to use time to cycle the end of inspiration. So in effect, a pressure control software design is control over the time that the pressure is set, with all else being variable. And you also want to be able to control how often the breaths are given. This lets you design the total breath cycle with inspiratory and expiratory portions. Let's move on. We're going to skip that one. And so this is maybe not as important for this group, but the unfortunately no lungs are the same. And so we do our best to treat them all individually with these machines. But in general, we have to make custom plans for every human that's mechanically ventilated. Let's move on. Compliance is a term that refers to the elasticity of the lung. This is a variable for many different pieces. A lot of it is the compliance of the chest wall itself. It can be a result of disease processes like fibrosis causing compliance changes. It can also be other issues in the body like sickness in the abdomen or pressure in the abdomen. All these things affect compliance. Let's move on. Resistance is simple for probably all the people here to understand, but this is an effect of our circuits, the airways that we use. Resistance is affected in the disease side by secretions and things obstructing airways. Stenosis and disease process that cause different sizes in airways is how we look at airway resistance. Let's keep going. There's a couple examples of that on the next slide. Just for the nurses, we try to help them understand that, the smaller the tube, the more resistance. Continue. That one's just for fun. Continue. So the advantages we get out of this are control. We can isolate the patients this way by getting a closed circuit with filtration. It's an advantage in treating COVID since PPE as a whole is not totally effective. Isolating patients is key. There's some discussion around early intubation being good and bad, and I don't think we'll know until all this is over. Let's go ahead and continue. The main focus for the ventilatory side is keeping a balance of the patient's pH. Usually this is compensating for the amount of CO2 in the body, which we try to keep around 40 for most people. This is done by moving the right amount of air in and out of the lung while we have them sedated and not spontaneously breathing. Let's continue. This is the main challenge with designing a ventilator for COVID patients is controlling the amount of oxygen support that we have aside from the mix or the fraction of inspired oxygen we provide. And that's through mean airway pressure and PEEP mainly. Let's continue. We don't need that one. Continue. And actually, that's about done if you guys want to field questions, because the alarms is the next slide.
Great. Thank you so much. We have our first question coming in from James Mertz.
Hi, Daniel. This is James from JPL.
Hey, James.
Quick questions for you. What are the control modes that are kind of a must need for a ventilator design that you're looking for?
I'd say the pressure control mode at a minimum is what we need.
Okay. And then how many are you needing and when are you needing those?
Ventilators?
Yes.
That's a very good question. At Keck, we have an uncharacteristically high amount of ventilators due to the acuity that normally lives within our facility. In terms of ICU capable or traditional ventilators, we have 49 that we would regularly use on patients. We also have 22 that we can use in the surge situation. So, we have a pretty large amount of ventilators here. In the county, I would say there is a tremendous need for a lot more ventilators, and I don't know how to guess exactly how many, but it would be, I'm thinking, as many as we can feasibly afford to get together. I don't think there's too little right now.
Okay. And then the final kind of question I have for you is an FDA approval required for a ventilator, or are we looking to potentially relax that requirement, or
So
what's kind of the deal with that?
The FDA actually has released a lot of information in the past week regarding ventilating patients and their devices. Traditionally, these devices would fall under the PMA or the 510K process for getting clearance from the FDA. Those processes have had releases from the FDA. As an example, Medtronic this week released and open sourced their ventilator that they were tasked by the government to design and build for this purpose, which I believe they only got to around 12,000-ish. It was supposed to be, I think, 80 or 100,000. They only actually ended up making about 12,000. That project was supposed to have been done in 2014 and then got pushed back to 2018. So as far as I know right now, they've made about 12,000. But they have released those designs and plans, and all you need to do is go to their website and give them your name and email, and they will release all of their design plans for that ventilator. That
Perfect. Thank
ventilator
you.
is sufficient to meet our needs.
Okay, did we have any other questions?
Yeah, and if you have questions for other speakers, so we could ask them now as well, and then we start basically moving to breakout rooms. So any other question for any of the speakers basically at this point?
Okay, fantastic. Then please bear with us. We're going to start
one
the breakout.
question, Stephanie, we just came.
Oh, okay.
Ozone?
Nick. Sorry.
Yeah, there are devices. Sorry, go ahead, Nick.
Nick, can you read your question?
I can read it if he's not on.
Sorry about that. Yes, my question is about ozone O3 being utilized in purification cabinets. Not necessarily for mass areas, I know it's regulated, but about its effectiveness against the virus and sanitation on face shields or on cloth face masks, any utilization of ozone that we could employ.
Kim, are you still on? Would you like to comment, or I can say what I know about that?
I'm sorry, I didn't hear what he said. I was
It's okay.
doing another task.
So he's asking about using ozone for sterilization. What I know about this is there are some devices where this has been standardized for cleaning things like home CPAP equipment. As far as in the hospital, it's not a standard for us to use that. I don't know the limitations of that or the efficacy, but all ideas I think are welcome. They just require some investigation and validation. I don't really know if there's a feasible way for us to bring that into the hospital right now. What do you think, Kim?
Yeah, no, I think there's pretty good standard guidelines on the CDC website that just came out around decontamination,
Sure.
Sterilization, what's acceptable. And I know Dr. Nanda is looking at that, like I said. So we're reviewing that together and hopefully more to come on that.
Awesome.
Thank you so much.
Jill, you're on.
Great, thank you. So I don't know if this is this isn't an actual question per se, but more along the lines of a request. I do have self-serving purposes besides just providing information. So as I mentioned before, so I operate the BSL-3 laboratory here at the Health Science Campus. And as of yesterday, we have just started our first SARS-CoV-2 infection. So we'll be doing the actual research, expansion, and work of the virus itself to start doing testing of therapeutics and other mechanistic aspects. So the PPE that we use, the personal protective equipment, is very similar to some of the needs that the hospital has. And we are actually lower on the totem pole when it comes to manufacturers and distributions. Basically, all the healthcare centers throughout the nation get kind of first dibs, and then the research labs we're told you'll just at some point wait to hear. So although our needs are smaller, obviously our researchers are doing expansions of these. The CDC requirement is biosafety level 3. So again, from the Tyvek to the actual respiratory protection helmets, we are also faced with kind of the same shortages. So again, I just wanted to kind of put that out that, depending on how this all pans out, we'd hopefully like to be able to request assistance and this collaboration should it be needed in the future.
So Jill, could you work with Kim so that way, we can have one channel to, and then Kim just let us know that, Jill needs that many, and then we can make sure that we can coordinate at the back end, basically.
That would be fantastic. Thank you for
that. Sounds good. And me and Dr. Nanda, our partners, work together. So I know she's interested in talking to you as well. So
great. Thank you so much.
Yeah, so just let us know via Kim, and that way, once we have the projected need, then we can start saying who's going to do how many face shields and respirators and those kind of things, right?
Thank you.
Mm-hmm.
All right, we have a last hand raised from Seth Weeman.
Okay, I had a question from those of us who are producing some of this PPE before we go off into the breakout sessions. Kim had indicated that she was interested in knowing how many of these things we can produce at what rate and when we can make them available. In our case, it takes several days to determine that information reliably. We have to go through a number of setups and refine those to some degree to get those numbers. One thing that would be useful to know is, are there some quantities on these, some minimum production rate that one could quantify below which one we should not even bother trying? I mean, before we go through this effort of figuring out what we can produce, if there is a rate of, say, if you can't make more than 10 a day, then it's not going to make a significant enough dent for you to go and investigate and optimize your process to give us what number you can produce.
Is that question directed to me?
I not necessarily. I mean,
Okay.
I'm just trying to, since we have no sense of what it's going to take to put a significant dent in the needs.
Sure. So when I said 6,000 face shields, that's covering our Verdugo facility, our Norris facility, and Keck. And that's all frontline providers for reusable. So if you're telling me, it would depend on how many groups are printing as well, right? So if you could do 10, somebody else could do 10 a day, and these are reusable, that makes sense, right? Because we could get a couple hundred out in possibly a short amount of time if we had multiple groups printing it. So for me to say it's kind of hard, I need to know what the resources are. And I mean, maximum, like I said, 6,000. If we say, okay, we can do 1,500, then focus those on one hospital or one area of the hospital. I kind of need to know what you guys are capable of producing before I can say what the minimum number would be, I guess.
So I was going to say, I look at my screen, right, and I see 25 people on the screen. And I say, if everybody who's on the screen can produce 10 a day for 7 days, right, which, may or may not be true, but that's even a week, right? That's 1,700 ballpark shields.
Exactly.
right, like 1,700
Those
is
would
the
be deployed
significant
already
number.
if we had that many.
Right. So like I agree, like one person may not be contributing that much, but that's the whole point of trying to bring everybody together, is that as a community, we can make a big impact.
And
Exactly.
just to reiterate on that point, we should all agree to the design we are following. We should not be each independently pursuing our own thread, because then the testing them will be very, very hard.
Well, I mean, agreeing to a standard design is a little complicated because we each have our different capabilities. And so a design which may be producible for one group may be more difficult to produce for another. Also, we're running up against different materials availabilities. And so if we can remain somewhat flexible on the design to accommodate different materials, then
Yeah.
that might allow us to keep our production rates higher.
Okay.
Yeah, so Seth, I totally agree with that. I mean, we're out there educating our healthcare workers that we want to ensure your safety. It may be a different color, it may be a different fabric, but it does the same thing. So I think getting one standard design is great, but if to get the amount that we need that actually meets our infection prevention requirements is 3 different models, I don't have a problem with that. I know Daryl is being tasked with a lot of emails. I am too. You all are welcome, the designers, to my cell phone as well. So we can make sure that what you can produce meets our needs. I will tell you, we will use it. Because I realize products are different out there. And, I mean, coverage is a big deal to me. And that's the main thing.
So in terms of the face shield designs, basically the way that we're looking at it is the headband portion is adaptable. We can print different models for it. If you're only capable of printing one of the designs, we're going to figure out designs that are universally available for the spacing on the face shields. So what we want to do is we want to standardize just the holes on the face shield. So if you're going to be cutting any face shields, they're interchangeable across the board. That's sort of the design constraint that we want to keep with as a minimum amount, right? And that we want to make sure that there's enough useful shield to cover our people. Those concerns are basically the only guiding factor in terms of the separate production of face shields and the band design. In fact, we realized that the band design is not going to fit everybody. And so we've been talking with designers to see if we can have other models that we can print smaller quantities of that will adapt to other people's head sizes, but use the same hole placements. So Seth, I will get back to you with the exact dimensions of for the face shield cutting.
Okay.
And I'll send you a couple of different models that we are printing for the headband design, if that would work.
That's certainly helpful. So I understand, are we not using the SMP engineering standard anymore? That's
right now, since we're going with trying to get the city of LA to join in and partner with paying for a lot of this, we're trying to use a model that is standardized with CEDARs, just in case that we need to interact with them in terms of supply. And I think it makes a lot of sense to go with a model that they've already started deploying at their hospital, just so that we can supplement our numbers if need be. Talking to the maker spaces that are providing them with PPE, they've been standardizing to that this whole spacing that we the Budman version 3, version 4 that I presented earlier. And so if we can make all our productions the same, then if worst comes to worst, we can start sharing.
But can you upload the files?
Yes.
Because otherwise people can't access files.
I believe I've uploaded it to all the Slack. I will. I'm meeting with our web team right after this meeting to set up the entire website as the central download for KEC. They'll have the most up-to-date models. It'll have the most up-to-date information, and we will be putting in our disinfectant guidelines on what we think is the best procedures for that. And we'll make it as part of our COVID-19 response websites, so people all over can centralize and access. And also, for those clicks, they'll be able to see more information about COVID-19 on our main keckmedicine.org site.